We are moving to the next panel in this auditorium, which is basically which is about the people's movement against TB, innovations in the community engagement. To moderate this panel, I request Ms. Kamalini Mukhopadhyaya kindly help in moderating this panel. We have the esteemed panelists, Dr. Nishant Kumar, the Joint Director from the Central TB Division. We have Ms. Blessina Kumar. We have Dr. Sairu Philip. We have Ms. Anisha Singh, Mr. Mohan HL, Ms. Richa Sharma, and Dr. Ramya Ananthakrishnan. All esteemed panelists, please welcome to the dais. Let's have a very engaging panel on innovations in the community engagement, the heart of the entire ending TB strategies. Welcome all the dignitaries on the dais. I also request the moderators to please come on the dais. Over to you. Over to the moderator. Again, we are live streaming this session, and this session will be available for a future reference also. Over to the moderator.
Okay. Thank you. Good afternoon, everyone. I would like to say at the onset that I'm extremely nervous, and because I've been asked to moderate a session which has a full range of very eminent people sitting here, and I am hoping that I would live up to half of what I am expected out of the moderator's role. Nevertheless, this panel is extremely important because since morning we've heard a couple of times the eminent panelists pointing out the need for the engagement of community, making this program beyond what it is as it currently stands. And hence it will be extremely crucial to hear from each of you what have been some of the experiences that you've had and some of the learnings that you could share with each of us in terms of what works in community engagement, what doesn't, what are the kind of challenges that you encounter, and what do you think the program should do beyond what it currently does, so that some of these challenges that you're focusing on can be addressed through. My first question would be, Sir, Dr. Nishant, to you. You're part of the Central TB Division, and you've been closely engaged, as many of you others have been, in developing a guideline on community engagement way back in 2021. And that has been kind of a landmark guideline. Going forward, it has been about 4 years that the guideline has been introduced. So, sir, if you could share how does the NTP program therefore envision some of the ways in which an effective community engagement happens or should happen in the context of the program that we have currently?
Thank you. First of all, thank you for including the program in the panel, because the ultimate aim is that the community should, lead the program. The learnings have come from HIV, the way NACO. So it's not that the community engagement or community involvement was not thought of. It's not that it's a recent phenomenon. It's been there since the program started. But what revolutionized, I would say revolutionized, but what has given the kind of attention to this component was well envisaged and documented in the National Strategic Plan 2017-25. So there's due diligence happening. Most of you who are in this hall, outside this hall, but they were there in the morning, were part of that strategic plan where the community engagement component was given its due, and the vision of that document as far as the community involvement for ending TB is, community-led and patient-centric TB services in India, and then there's different strategies are documented. So those were the times, let's say about 8-9 years back. And the strategies which were there, how we implemented them, I'll just try to walk you through that. There were main 3 strategies that, first of all, to institutionalize this platform where community can actually participate in a meaningful manner in policy making, in the real-time feedback. So we institutionalized TB forums. That was a forum where the program implementers, the administrators, civil society, TB survivors, TB patients, families, they were given a platform to contribute to improve the quality of the TB program. So that is first. And over the years, we evolved this component of having community at the center stage. It took us time. Just to give you a perspective, when we started, and as I said, the learnings came from, a lot of learnings came from NACO, and TB epidemiology is totally different than that of HIV. And to start with, to form those forums and getting the TB survivors on table and in a group was a difficult task, both on the programmatic angle also. And initially, for first couple of years since 2018, the forums were actually not represented in the way we envisaged. So when we reviewed slowly now, but we have come to a stage that we have the TB forums at the national, state, and district levels, and now they've gone beyond state. So that is one strategy which has evolved over the years, and we are getting a lot of feedback from these forums how to improve the quality of services. Second strategy was to involve the TB survivors, build their capacity and take their support. I'm deliberately using this word, taking their support in addressing the biggest gap in the TB program, that is awareness, because the national prevalence survey shown us data that 64% of the population who have typical symptoms of TB don't seek care. They seek care late. It has bearing on the treatment outcomes. It has total direct bearing on the TB mortality. So that's where involving them, training them through our partners, Reach was supporting us. So over 6, 7, 8 years, we worked, and we, it was not an easy task to find committed TB survivors whom you train and then they work with to support the program, not with the program. I'm being very careful that we don't want to be seen TB survivors or TB champions to be part of the health system. They should be the mirror to the health system and give the positive feedback. Third strategy was, of course, not to reinvent the wheel, use the existing mechanisms of raising the TB awareness, TB as an agenda across existing mechanisms, that is village health and nutrition committees, Mahila Arogya Samitis, and that we have successfully been able to done. The involvement with Panchayati Raj department is one such case. So in the interest of time, I'll stop here in the first round, and maybe I can respond and in the second round. Thank you.
Thank you, sir. Right. So we just heard what the program had envisioned in terms of how to engage communities. I would therefore ask Ms. Blessina, you've been leading the Global Coalition of TB Action for a very, very long time. What do you think have been the contributions that people-led coalitions like GCTA have been doing consistently over the years? And how do you think it can be providing inputs onto the program?
Thank you very much for that question, and thank you for this session and bringing the community experience to the midst of this innovation summit. GCTA, the Global Coalition of TB Advocates, was set up because of the gap there was of people's involvement within the TB response. Way back in 2013, it was recognized. In 2014, along with the support of Stop TB Partnership, we launched it. But we found that the TB response was extremely different to the HIV response. almost all the community champions, what we call today, in the TB response were all from the HIV movement. There weren't any TB champions at that time. And we really felt we needed to do some deep dive and bring about a change that is lasting. So I want to give an example of one of our best stories, our success journeys. So when we started, we kept hearing about stigma. TB survivors would continue to tell us that stigma was a big challenge to access care and treatment. So when we took this to the policymakers, they said, no, there is no stigma in TB. It's pretty simple. You go, get diagnosed, you get treated, 6 months, and you're fine. But yet we kept hearing about the stigma issues from across the globe. So we decided to do some evidence generation from the ground, and we brought out the first booklet on women and TB stigma, and had about 11 women from around the globe actually tell their story. And it was so impactful that I remember the director of the TB program in WHO saying they couldn't finish reading the book without bursting into tears. So slowly it started making sense, and people were realizing that stigma is a big barrier. And we launched the booklet at the 2018 first UN high-level meeting. And people started really thinking about stigma seriously. And larger NGOs started thinking about stigma. Donors started putting in money for stigma interventions. Programs around the globe started considering it. And the India program, I must congratulate Dr. Nishant and the program heads for taking us seriously and really listening to us and saying, yes, it is a problem. So we went on to generate this. We launched it, and then we came back to the country level and we said, can we do something about it? And along with partners who are sitting here like KHPT, Reach, and others, we went on to develop the national strategy for eliminating stigma and discrimination associated with TB. And this was with the blessing of the program. And we were very proud when in 2021, the Minister of Health launched this national strategy. So we didn't leave it at that. So we got evidence from the ground, took it to the highest level, and now we had to take the results back to the ground. So we developed a training module based on that national strategy and started training people at the field level, the STOs, the DTOs, the ASHAs, and other healthcare workers, to understand what is stigma and how it plays a huge role in being a barrier to accessing care. So this is a full circle. From the ground evidence, changing policy at the highest level, and then bringing that back to the ground level is something that we have learned to be a great example of a best practice. And this can only be done with the people. The stories were from people who had been through that TB journey. If you haven't gone through, there is always you and us. But if you have gone through this, I will never refer to a community as them. I will refer to a community as us, because I am part of that. So I think an understanding that when people come together and join forces and we treat each other with respect and listen, there is always a success. So with the cooperation of everyone, we were able to make addressing stigma a real thing within our TB program. And now the next step would be to make this training available across the states. We've done it in 4 or 5 states, but I think this needs to be done in every state, and that's something we would definitely be looking to the program for support. Thank you.
Thank you, Blessina. I think that was a very, very important point that you flagged about stigma. I think we have heard a couple of times again since morning being talked about. And I guess more and more conversations around stigma are happening nowadays than it was happening way back. Picking up from your point, my next question would be Dr. Sairu Philip. Ma'am, you've been part of the STF Kerala for a long time, and panchayats are some of the key ways in which you connect between people and programs, or in general, the systems. In your experience of working with TB-free panchayats, particularly in Kerala, could you highlight some of the important strategies that have allowed the panchayats to be a better platform for connection?
Thank you so much for that question. In Kerala, the tuberculosis elimination mission operates under the stewardship of local self-government. Now, this decentralized mode of operation gives them independence because there is financial devolvement to the panchayats, and they are in control in order to plan and implement TB control activities tailored to the needs of the community. I still remember in 2004, one of the health workers went and said to a panchayat president in Alleppey, Mohan, that a person cannot, taking medicines for TB, did not want to take it because he didn't have any food for that. So they devised their own plan fund. They set about their own plan fund in 2004 in order to provide all the TB patients then under treatment with egg and boiled plantain. So what I mean to say is that they listen to the voices of the people. So knowing this felt need, or rather the decentralization and local self-government stewardship, I would call that the hardware to boot in community engagement. Now, to think of the software part, the first thing, positioning TB elimination as people's movement. It is like placing the responsibility upon their own hands. So the thinking is, okay, I do this, my place will become TB free. That means my children will not get TB, the next gen, we will have better air. So doing things for their own good, for their own environment. And when every ward becomes TB free, the panchayat becomes TB free. So when every panchayat becomes TB free, the block will become TB free. That is the encouragement given. So positioning TB elimination as people's movement does this. The second is the philosophy. Now, the learned people may ask, is TB there still now? Why should you devote so much of time for this TB elimination? Then the philosophy is, whatever activities you are doing under the TB elimination program, it is going to strengthen your own health system, which will help you to combat all the respiratory infections prevalent now and to come in future. Now, at the background of COVID-19, it is easier for the community to understand. Third, I believe, is the success of a TB-free panchayat is the political will. And fourth, a passionate local champion. It could be anyone. It could be a TB survivor. It could be even a medical officer. It could be someone, a passionate local champion who will stand by this. It even could be the ward member. So some grassroots influences are required in order to keep the movement going. Another thing which I feel is linkages with the primary healthcare system. Because if you linkage with the primary healthcare system, when you move together as a group, things will work better. So TB-free panchayat, all the task forces were decentralized. So people felt that it is their own, of the people, by the people. Of course, challenges are there, like when there is change in leadership, competing priorities, calamities, it is there. And how to innovate upon this community engagement in the context of TB-free panchayat, I believe, one has to address the social determinants that go along with the disease and illness. So like the nutrition program, addressing their needs, that helps in community engagement. Second, I feel is we talk about BCG vaccination. I feel in the next era, we should have BCC vaccination with boosters. BCC, I mean behavioral change communication in a very intensified dose and with boosters. So I think that is very much, that part need to be thought of. Again, convergence. convergence of different stakeholders, still now difficult with all the egos, with all our compartmentalization. So convergence, that is an area for innovation for community engagement. And I feel distinctions and awards. We had given TB-free panchayats who could make their pediatric TB zero, some encouragement, some awards. So that can motivate people. And I think the digital tools, that could also help in future area for innovation. And I feel as part of research now we have to think how you engage the younger population, the generation isn't in community engagement and in areas which the elder generation used to take up very easily. So I think the TB-free panchayat comes from a people's movement, and that is what I have to say in the first go.
Thank you, Dr. Philip. I think you, amongst the 4 points that you mentioned, the last one caught my ears because you mentioned about picking up information and technology to be using it better with the new generation. And from here on, my next question would be to Ms. Anisha Singh. Anisha, you've been heading the NTSU since a while now, and you've done a fair bit of communications related work. So in your experience, can you share what works and what doesn't in ensuring a greater participation in people's movement, particularly in the context of TB?
Thanks, Kamalini. I think before addressing that question, I'd just like to, make an observation to your initial comment into what is working. So like Blessina said, inserting a topic like this, which is non-scientific, in a conference or in a summit which is largely probably focused on scientific innovations, I think is a great step in that direction. However, the gap is that you see the participants, even if half of what was there, of those who were there in the earlier sessions, I'd like to see that as we go forward, then it's actually going to be a people's movement. Otherwise, no, that's fine. It's not for you. I'm just saying that that's the direction or the shift we all need to move towards. Otherwise, it'll remain in conversation here. So that was just, that's my dream that, 2 years or 1 year, hence this hall is as full for this session as it is for technical sessions. But having said that, coming back to your question, and Dr. Sairu, I think you've addressed and touched upon all of those people movements, points as to what works for something to become really a mass people's movement. But I'll just, and so pardon me for the overlap if there is any, but just want to start that, first want to lay out with, what the definition, or loosely how would we define people's movement? It is the whole of government, the whole of community, and the whole of society sort of approach. And I consciously differentiate community and society here for the sake of this conversation, because when I say community, I'm referring to the TB community here. In India, large-scale public welfare programs like the Swachh Bharat, etc., have demonstrated this approach of people's movement quite successfully. If I may say so, brought toilet conversations into the drawing rooms, right? Of all of us talking about toilets in the drawing rooms. Similarly, when we talk of this movement on TB, the momentum has already started. It's already like we were talking about pressing buttons in the morning. So that button has already been pressed. And it is exactly about this, bringing the topic of TB again into drawing rooms, if I may say so. And that sort of alludes to this conversation that we were having about stigma and TB conversations not being normal and, all of that. So that's what, the idea of a people's movement is. Now, this whole of approach that we were talking about, what does it do? It raises salience, and it really feeds into this concept of social proofing, which is where this whole stigma aspect also comes into place. So the bigger the proportion of people that accept a behavior, and in this, if it is demonstrated in various ways through pledges, through testimonials, through policies, through endorsements, etc., then the greater the notice is given to the option, right? So in this case, then I will give greater attention to making the choice of adopting health-seeking behavior, because it is a socially accepted sort of norm, right? Or even to framing policies. so I will be pressurized to frame policies which help end TB in the country. So that's what I think the people's movement thing really does. Now coming to, what motivates people to join this movement. I mean, there are many things, and Dr. Sairu, in the context of the Panchayati Raj involvement and TB-free panchayats, has explained all of that. But if I were to pick out, I would want to pick out like just maybe two things. One is leadership, which Dr. Sairu also referred to, and the other is salience. So again, in the case of TB and Swachh Bharat, etc., led by the top political leadership, Swachh Bharat launched from the ramparts of Red Fort by the Honorable Prime Minister, ending TB goal, again clarion call given by the Prime Minister, right? So it does not, it should not stop there, right? Under the Swachh Bharat program, and I'm giving lots of examples of Swachh Bharat program because that's an experience that I've had. There was this popular PM-CM-DM approach, right? It is led by the top leadership, but followed with equal fervor and enthusiasm and responsibility by the Chief Minister and then the district magistrate, and that's how that accountability at all leadership levels leads to an actual truly structured sort of people's movement. An adjunct to this, I think, is a regular reporting and review. So it should not be, we were having this multi-sectoral engagement with, during the 100-day campaign, and I think the secretary, madam, actually very clearly said that it should not just be left in DO letters, right? It should actually be implemented and reviewed and course corrections to be made. So I think that is the second part of it, actually becoming a people's movement and not just a lip surface. And the third adjunct that Dr. Sairu also spoke about is the reward and recognition part of it. Appreciate people who are actually making that difference, and appreciate it again, not lip service, but actually truly appreciate that. And just the second point that I want to talk about is salience and visibility of others doing the same thing. This can, of course, be done in many ways, right? Of course, use of mass media, community-led interventions, which are visible on the ground, high-profile events which celebrate achievements, testimonials, basically all the stakeholders talking about the same thing in an integrated manner, right? And you remember the Gandhi Ji ka chashma from Swachh Bharat, you would see everywhere. Do boond polio ke, zindagi ke, to see, you see everywhere. So I think getting that one visual identity and using that to unify the whole, people's movement is, I think, a very important aspect, of a people's movement. So these two things, which is, I think, leadership and salience, are two important things to make a people's movement successful. Thank you.
Thank you, Anisha. I think point very well taken that we should be looking towards having much more engagement, both on panels such as this, but also down at where it actually matters in terms of improving upon or engaging more of community when we think about it in terms of people's movement. My next question would be to Mr. Mohan from the Karnataka Health Promotion Trust. So you've been heading the KHPT since a very long time now. I know Dr. Sairu talked about the role of Panchayat, but if you could also share some of the innovative work that KHPT has been doing in terms of engaging communities, particularly in the TB space, I think that will just add on to the existing information and knowledge on the panel.
Thank you. Thank you for this opportunity. Maybe before getting into the experience, I always used to wonder with few questions about the people's movement. This is not something, TB is not something new for our country. So many other communicable and non-communicable infections we dealt with. Being it is HIV or COVID at one side, we also dealt issues like polio in a big way. We're able to do some kind of justice with people's participation. We are taking some more time for the TB to ensure the people's participation. Why is that? Is it not people are not interested to take the ownership, or something which with our own strategy where we need to address few of the things? Dr. Nishant very clearly told our policy talks about ABCD. I think if we are able to turn out to these things at the field level, really it is going to be a people's movement. We drawn a lot of our learnings from HIV, no doubt. There's a school AIDS program was there at that time. But do we have something on TB at all level? We don't have. The program used to become very parallel program. We talk about entire morning today, we learned about diagnosis, treatment, adherence, blah, blah. Now we are talking about other part, which is most important part, according to me, where you are trying to prevent. We are talking about social determinants. We are talking about nutrition. Okay, we are talking about stigma. These are the aspects. If we want to make this to happen, the only possibility is ownership at the lowest level. We used to talk about TB-free district. Now we are talking about TB-free panchayat. We see the ownership should come at the panchayat level. So the stigma, nutrition issues will be, other determinant issues will be addressed at the lowest level. I see there is a possibility if today around 59,000 panchayat out of 2.5 lakh, panchayats are applied for TB free. See, it is very, very positive sign. They have started taking the ownership. It needs to be much more robust. I share one example from last 2 years. 4th state, we tried to start involving around 10,000 panchayats. And we just told that panchayat, we gave some kind of a kit. We didn't talk about only TB. It a bit of a convergence. We know that health and people, somebody need to link between. Who is the right person to link? We thought panchayat is the right person because 73rd amendment of the constitution, it mandated panchayats to work on the public health issue. So we told, okay, you do it. So within a month, in one state, within a month, they are able to verbal screen around 10 lakh Manrega workers. Because Manrega program is implemented by panchayat, SHG program, federations, Jivika, all are linked with the panchayat. When we started doing the micro planning, there are enough number which panchayat can reach much better than the health department. So now when we started talking about this, the stigma is the issue. See, it has to go when the people start talking about TB. It won't go just like that, right? More and more people, when they start talking about, it will be generalized. Same thing happened in the HIV also, how it was earlier. So now, around 7 million is screened on it. Along with NCD, 5 million people by the panchayat themselves. Who screened? Health department. Who coordinated? Panchayat department. So exactly like the Kerala example, the ownership at the decentralized level. Now we are seeing other aspect. We are talking about resources. Panchayats have a mandate to collect health cess. So far, this health cess is used only for water, sanitation, or some cleaning, drainage, blah, blah. And recently, we have seen that they started using this money, health cess, for the nutrition support and other camps they are conducting. So, what I mean to say, we have people at the village and the grassroots, they are very, very human. And they are the people, if they know, if they understand, they take the responsibility in their hand. If that is going to happen, that is one. The second part, she talks about the convergence. I'll tell you, this program or whatever will be successful only if multiple departments come together. We no need to put any effort. Panchayat is there. They're already doing different programs for different departments. So involving them as in a platform at that level, it is very important for us. So this is something which we have seen involving the panchayat and empowering them to address this kind of an issue will be a great success. Then only we can. For me, the people's movement means people's ownership. It is not just ownership of the TB patient, it is everybody. So then only we can see the people's movement. That is true in historically all our movement, whether it is science movement, whether it is education, whether now solid waste management. You see any program in the country that was possible only when people really took on their own. Thank you.
Thank you, Mr. Mohan. I think very, very well articulated about how this can actually become the panchayat's role can be envisaged into bringing in other departments and utilizing the panchayat as the platform, one of the best platforms to reach out to people and bring in that kind of convergence that we are all talking about. Dr. Ramya, my question therefore next to you would be, REACH has also been implementing a number of very, very innovative community care models across the country. It has been working very closely with the Central TB Division. Would you like to highlight some of these models within the TB care in community engagement that REACH has been, implementing at the field and the potentials of them being adopted and scaled up across by the program?
Thank you very much, and I just want to thank the organizers for this opportunity. So I just went upstairs to see the innovations, the search, detect, treat, prevent, and very fancy technologies, and I mean a lot of talk about handheld X-rays and AI cough app and things like that. But none of the technology will work if the community doesn't accept it, own it, and use it. And I think that is where community engagement and community involvement becomes mandatory. And when we say community care model, I think the minute we use any tool at the community level, it becomes a community care model, because I don't think we do any research or any intervention which doesn't benefit the community. So I think a lot of the innovations that we see are reaching to the community through the community care model. Now, as far as REACH is concerned, I think we've been involved in coming out with a lot of innovative community care models, starting with what Dr. Nishant mentioned, the whole TB survivors to TB champions movement, which where today the TB champions are on the map of the TB program, and they are considered a very important and a critical part of the national TB elimination program, and we have many survivors and champions here, and also presenting their own innovations, and very happy to see that. So we've been a part of that journey. How do we, what happened organically in HIV? How could we build the same momentum in the TB space? So that was a huge community care model where, and today very happy that it's been scaled up across the country through the Central TB Division's ambitious plans of having 2 TB champions per tuberculosis unit. At Health and Wellness Center, sorry. We've also been piloting a community accountability framework, where it's a community care model where, again, as Dr. Nishant mentioned, how do we have accountability? Because we have the TB program rolling out many services, but how can we have somebody who will tell us whether what is intended is actually happening? So it's a community monitoring, but a community monitoring with a slight difference here. The community accountability framework is where community monitoring happens along with the communities participating in finding local solutions, in generating, mobilizing resources, so that the gaps are just not found and flagged, but it's also addressed at the community level, because sometimes it's some very trivial, like no weighing machine in a health center. So you don't need CTD Dr. Nishant, sending a memo or anything to. It's very fundamental. So how can that be addressed? So simple things like that. How can we mobilize local solutions? Another innovation is the creation of the support hubs, where the TB champions worked at the tuberculosis unit level, providing services beyond TB. So TB itself has a whole range of services. What initially started with just treatment adherence, now there is DBT, there is comorbidity screening, so many layers, right? So how can TB champion support in, again, expanding the scope to a family-centric, to a gender-sensitive counseling, vulnerability assessment, identifying risk factors and linking them to de-addiction and smoking cessation. So that was something which we were able to provide through the support hubs, where the TB champions worked along with the health system, the health workers, to provide that kind of additional services. We've also been providing the peer-centered, person-centered care approach to migrants. Where we looked at this whole linkage, the people, the TB champions, since we had the TB champions across the country, we were able to facilitate in any language issues, because again, counseling, like regional languages are there. So how do we make the counseling and treatment literacy truly meaningful and understandable by a person with TB? So, and migrants face that huge challenge. And when they go back to their own places, how do you connect them? So we got the TB champion to connect to a TB champion in that particular district for a seamless migration and transfer of treatment in the new district. We've also been getting TB champions to support in DRTB care model, where again DRTB care is, it's not just a DRTB treatment, but also they need whole kind of support like additional nutrition support, livelihood support. So we had TB champions supporting them in even reducing the initial loss to follow up, basically because in a DRTB you have to go to multiple places for getting multiple testing before you're started on treatment. So you need a navigator, and that's where the TB champions came in as a navigator to help and guide and support a person with DRTB to navigate the pre-treatment evaluation and start DRTB treatment successfully. We also had a care model where we involved the women TB leaders, and because these were people in the community, and through them we reached out to all the SHG groups and expanded not just knowledge on TB, but on various range of health issues which the community felt were important. So besides TB, even other infectious diseases and child health, financial literacy, empowerment. In fact, we even taught them CPR, first aid skills. So again, that was a care beyond TB. And I think what was very fascinating about all these community care models, one underlying thing which happened in everything was the whole empowerment of the TB champions themselves while they delivered these community care models, because they were taught on various range of things, and one of the three very important ones were data. I think all of us in TB field know how TB program is so rich in data. So if you don't understand data and if you can't decipher data, you just can't work in the system. So so the whole data for action was, how do you interpret data? What is incidence? What is mortality? So just training them while they give the community care to a person with TB. So that was something very innovative. Again, communication skilling. So when we think about communication, communication, we only think about either mass media or videos or pamphlets and posters, but can we train the people to use different methods so that they can adapt and do whatever communication they would like in their own community? So so it's basically like teaching a person to fish and not just buying fish and giving it to them. So that kind of communication skilling workshop, and I think this whole component of community rights, gender, stigma. Today, a lot of networks were trained on how they could, as the program always envisages. So we want the TB champions, the community movement, to partner and be synergistic, not replace or not fill, because there is a huge program there, but how could they act in a synergistic way? So how do you assess the gaps in their districts? How can they ask the right questions? How can they look at the data and ask meaningful questions at the TB forums? So these were some of the models that we have implemented over the years. Thank you.
Thank you, Dr. Ramya. I think that was a very wide range of innovations and community care models that you spoke of. And I'll particularly pick up the one that you spoke on about gender, because what we have in our next panelist is Ms. Richa Sharma from the Women's Collective Forum. So Richa, my question to you would be, what has been the role of Women's Collective Forums in engaging communities for the TB program?
Hello. Yes. So I would like to begin with saying that, the nervousness that you began the session with, I think now I'm reflecting that nervousness because everybody who is sitting on the panel right now has articulated my insights with much more experience than, I can ever bring to the table, especially when it comes to TB. But having said that, so the idea at Women's Collective Forum and how we arrived at working in TB was because we're working on this project which is across 18 themes on advancing public health outcomes across the country. So what we've tried to do in this exercise is to engage with research institutions, educational institutions under each of these themes. They range from, say, tuberculosis to malaria to, innovating healthcare outcomes for women, adolescent health, etc., right? So one of our best experiences amongst all of these exercises was working in the space of TB and entire community around tuberculosis, because the moment we came out and said that we are doing this exercise, we had people from the union to NIRT wanting to collaborate and eventually collaborating with us. And what we've managed to do is to undertake 3 Chintan Shivir of a sort. And these consultation sessions that we have been able to organize in Delhi, Chennai and Guwahati. So in collaboration with NIRT, so what we're right now trying to do is to build a policy blueprint of how maybe it's going to look like India's progress in the space of addressing the challenges in tuberculosis, right? So, and I think everybody is underway in terms of developing that report in collaboration with NIRT. NIRT holds the penship for how they're going to be addressing each of these issues. So, for us, it's the innovation lies in how we structure policy around any of these themes. And for us, the pyramid, like the top half of the pyramid happens to be these the policy makers, institutions like NIRT, the Central TB Division, and everybody else that's at the top half of the pyramid, and the bottom half is the community that we are sort of looking at, right? Which we're trying to address, and issues like stigmatization and everything. So what our eventual, as we brainstorm through our process into developing that report, what we figured is the community has to be approached with a lot of strategy. Right, so and divided into cohorts. So for us, one of the key cohorts, because we're the Women's Collective Forum, happens to be gender, right? So like institutionalizing or mainstreaming these conversations around the impact of, say, the health economics point of view on gender, maybe the stigma. Like I was just reading to, and we were just going through a lot of conversations around that. Is around what is the chances of stigma around and which is faced by women is much higher. So stuff like that, right? Like, so we've figured that those things. Another very important one that supplementing to the conversations that have already happened is the adolescent community. So when we're talking about, say, information, education, and communication, which happens to be one of the key models in which community engagement is undertaken by, from a policy point of view or from, like a private practice point of view, adolescent is the next generation. So we need to, that stigma need not get reflected, that has already existed in the society, need not get reflected in the future. So those are the kind of things, and ma'am rightly said, right, like there are these brilliant innovations that are happening. At the same time, there's this really like a very interesting one which is addressing the adolescent population, and it's all to do with developing sudokus and puzzles, and how, like the entire conversation around tuberculosis can be crafted for the consumption of the adolescent population, a very particularly important cohort group. So, I mean, those are some of our learnings that we have, gone through in the process, and which I thought we could complement with in this. We could complement by, placing in this panel. And thank you so much for the opportunity.
Thank you, Ms. Richa. Thank you. That was very, very well taken and quite innovative in its approach. In the interest of time, I think I'll go back to the entire panel for a minute from each of you to ask you, therefore, from all your experience and from all the policy making that is currently happening, as well as the work happening at the field, if there's one message that you would like to give to the program in terms of how to strengthen the community engagement component so that we move from what it is in terms of community engagement to taking it to a people's movement level, what would be that one thing that you would ask the program for, or for in terms of research or in terms of innovations? I'll start off from Ms. Blessina and then...
Thank you very much. I'll try and give 3 in a minute. I think the first thing is to realize that communities are the only conduit for reaching the last mile. And, they are not just passive recipients of care. Communities can and should be valuable partners in the program. And I think that's very important. What is needed for that is to be treated with respect and to be listened to, because you've been through the journey and you understand what TB does to you and to your family and extended community as well. So I think that's important, and to involve the community right from the beginning. What we see is that everything has been planned, and at the implementation level, and this is not just the program, even NGOs, even CSOs, we plan everything, we design everything, and then the last minute we say, oh, where's the community? Let them implement it. I think a better way to do it is actually to bring the community on right from the planning stage, because communities have valuable inputs. You may be planning it in a wrong way, or you may benefit from that. So I think bringing communities in right from the beginning is very important, and also ensuring sustained funding. In this challenging environment, everything seems to be from project to project. Your project is for 3 years, you do amazing work. At the end of that project, the champions are left. They don't know what to do. So how do we come up with innovative models of financing that go beyond the project lifespan, that go beyond the time where they are, expected to provide you with information, but that they can really stand. And we have great examples from India. Somebody did mention self-help groups. And I think we need to actually look at this. How can we give that independence to communities if we really want this to be a Jan Andolan, a people's movement, then it needs investment. We are investing so much in innovations. For the floor above is filled with the gizmos, which is great. But if you do not have a community that have access to that, that's a complete failure. Any innovation, if it doesn't reach the people who need it most, we have lost the battle even before we've begun it. So when we think of investing, I think we need to really bring the communities in, because communities can also help in a lot of things. Like, we have advocated for price reduction. We have advocated for access. So I think it's very important to understand what people's movement involves. Are we ready to invest in that? Are we ready to see this through? I think that's when we can confidently say, or even think about a TB Mukt Bharat, talk about elimination confidently, if we have the people on board with us as valuable partners as we move along this journey towards elimination. Thank you.
Thank you, Ms. Blessina. I think that was very, very emphatic in your words that was coming out in keeping community at the center and encircling everything else around it. Dr. Sairu Philip, over to you for a remark.
I think we should leave no one behind. So whatever innovations and research, should we consider the personality of the community? I think each community is different and unique. So try to understand the personality of the community and deal accordingly. I'm apprehensive of those minor numbers. For example, the adolescent girls, unmarried women, youngsters who seek job abroad, alcoholics, destitutes who seem to slip out of our fingers. So leave no one behind.
Thank you. Again, another emphatic line, leaving no one behind. Ms. Anisha, over to you for one remark.
Thanks. So I think since I'll talk to the research part of it that you said. So I think the social science research, which we've been talking about, also is a very important aspect, and that's something that we should consider, as a TB community to sort of undertake. And given that we are doing this people's movement in India for TB, if we can document that and document that journey of from where this movement started to where it's arrived and what have been the results and impact, I think that will be a very good, very important contribution not only to the TB program in India, but even from India for the world kind of perspective. Just to give you an example of, again, I'm going again back to Swachh Bharat, but in the 5 years of Swachh Bharat, the cash and non-cash kind of equivalent worth that this whole people's movement managed to achieve, an independent agency did it. It was about 26,000 crores, but actually the cash value of that was only about 5,000 crores. So the 2 points I'm making here is that it's something which is people's movement can do up to 6 times, 7 times of what your actual cash worth is. And second, because they documented it, they are able to talk about it and demonstrate it. So I think from a research angle, the social science research aspect, we must focus on. Thanks.
Absolutely. Social science research in TB and in engaging communities is what we should be looking at. Mr. Mohan, your point on...
Thank you. Going back to what we spoke earlier, I want to emphasize 3-4 things when I take the people's movement, how we can achieve something, basic characteristics like we spoke a lot about accessibility. Who is accessible? The people near to the community, and that is Panchayat. Is they accountable? They are accountable. They are elected. Every 5 years they go for voting. So they have accountability to the people, number one. Number two, inclusivity. As per our Indian Constitution, the only level that the Panchayat level in democracy, there is a reservation for women. So women participation is ensured. Same way, even SC, ST and other communities, reservation is also ensured. So there is an inclusivity, because this disease affects the vulnerable population. Number two. Number three, where we can ensure the participation. There is a Gram Sabha, there is the VHND, there is VHSNC, there is JAS, there is a multiple number of committees. All these committees coincide with the Panchayat. So there is some kind of a participation they can enhance. The fourth one, decision making is very important. We all talk, ASHA, frontline worker, all department line, but the decision making generally lies with the panchayats. They have right to spend, they have right to collect taxes. So the decision lies at the lowest level. The fifth one, financial devolution. They receive money from the exchequer. So they have some kind of an untied money as well to spend for the need of the local people. How they can prioritize like TB kind of an infectious disease. Convergence possible. We know that it is always difficult to achieve convergence at the state level, at the district level. But when it goes down, it is the family. We have to bring everything together, whether we want it or not. But the people want to be things to be addressed together. The last, we know that, this is for me like a pot with a hole. We are trying to fill one end with the diagnosis, treatment. It's equally important, but there's also things going out. We need to stop that. See how we can balance the community prevention at one end, at the same time also work on the diagnosis, testing and adherence, blah, blah, blah. So both the things need to be balanced. I don't see that kind of a balance is there. But good thing, positively, last couple of years, I think Dr. Nishant knows very well, lot of these preventive measures and preventive policy, preventive experiences happened across the country is a part of the policy now. And now the campaign is launched and TB-free panchayat, so many initiatives where the community is taking the lead, like even Global Fund is more on now on the community engagement. So I think that is the very positive sign. And once we are achieved this, I think it will be very good to integrate these TB champions, being it TB survivors or caretaker or the panchayat or the facility person, anybody can champion. Nikshay Mitra kind of a program can be dealt at the panchayat level, because we know that in the villages we hardly see beggars, hardly people go. But in the urban we see. When we can able to achieve pandemic like COVID, with tracking, isolating, everything. Why not do we do this? That is possible only if everybody participates. So there is a possibility if you really highlight more decentralized way of addressing these issues. Thank you.
Thank you, Mr. Mohan. Dr. Ramya, 1 point from you.
Thank you. So I think all the previous speakers mentioned about how communities are very critical if we have to have this Jan Andolan. And in fact, morning, one of the dignitaries was talking about co-creation. And I think one of the player missing in that co-creation was affected communities. So I think it's important for them to have a seat at the table, not because we need to, but also that what will meaningfully inform both program and research. And a couple of things, because specifically with respect to research, I'd like to say that today innovations, research and community engagement are in silos. So they are not talking to each other, they are running parallelly. So you have a huge network of people doing a lot of care at the community level, but which doesn't show up because it's not in the scientific community. And I think the scientific community is missing out on a lot of excellent community care models because they don't have the bandwidth to write papers, scientific publications. So I think as ICMR, it would be good if you're able to invest that kind of time and energy and resources for working with the community-based organizations, survivor networks to build their capacity and also to help translate their research into scientific publications, and also the research methodologies itself. Because I mean, generally, any grants or any research, most of it is all fancy research, diagnostic, drugs, RCTs. But I think we are missing out on a whole range of, as she mentioned, the previous speaker mentioned, the social research, and we need new methodologies on how to showcase at work, which would be a great learning, and partner with a community-based organization because then I think as a country and for the TB movement, we've done a lot of pioneering things, but if we are able to marry community and research, I think that would be really a big thing. And communities need to be involved, as mentioned, from everything, right from along the care cascade, be it community needs assessment, community advisory board, continuous community feedback. So they are needed at every step of the way. And until we do that in a meaningful way, it's going to be very challenging. And it's always TB will be only in the scientific community and will not reach the people at the community level. Thank you.
Thank you, Dr. Ramya, for that insightful point. Ms. Richa, over to you for 1 point, and then I'll get back to Dr. Nishant.
So one of the most the thing I want to say, add is that I think availability of data, when we're looking at integrating AI, machine learning, and that kind of stuff into disease modeling and in TB and trying to bring out that kind of solution, I think the availability of data with research institution has to be also consistent and in a proper format that's consumable. So I think that's going to be one of my additional point to it.
Thank you, Ms. Richa. Dr. Nishant, sir, over to you. You've heard the entire panel, you've heard the innovations, you've heard challenges, you've heard what this panel emphatically wants to put in place in terms of moving from community engagement to people's movement. Your final words on that.
So, first of all, I'll thank all the panel members in putting up the right question and at this panel, but I would like to thank all the partners. Some of them are in this panel sitting here, how they supported and how they worked hand in hand with the program. So Dr. Mohan pointed out that we said the theory part of it. So in the first, so you have to, I'll request to give some time for program to respond to all the questions. I'll try, I know. The good thing is that this session was very, very interesting, and we heard the right, and thanks for the organizer to choosing the panel who had put us gave us the insight what needs to be done. So what needs to be done was written in the NSP, which I said. What we did is something which I want to share. You give me a minute. I'll try to answer all the questions there. So I would say that all came. The perspective of community engagement changed when on 13th March 2018, an honorable Prime Minister said something very, very important. What he said, that if we are doing things in a certain way and they don't bring results, we have to think different ways to do it. And he said another thing which was directly related to how important the community engagement is that in that summit, one of the TB champions spoke about his experiences, and he said, when somebody who has gone through this disease, having experienced it, comes to the community listens. So that these are the two things from where we started. I think this was in March 2018. In April 2018, we started working together. All the partners are sitting here. Reach was supporting us, KHPT was supporting us in South, Japaigo was supporting us in the East. So today, since it's an innovation summit, what innovation in community engagement, though it's very difficult, we can't match with somebody building up a drone or scientific equipment or diagnostic tool. Social science is and there is a lot of social science behind getting the community and making it a Jan Andolan. So I'll take 2-3 examples how we can, in my view, call innovation. First of all, we broke the silos, and as somebody very wise has said, there are no accidents. So somehow I had both the components of community engagement and the ACSM, the awareness, advocacy and social mobilization. So what changed was, like, we broke the silos. We got all the partners supporting us in these two areas. And we met from 2022 to 23, I think about 20 to 23 times in different workshops, the same group. That was one thing. A lot of talk has been talked about, Dr. Mohan talked about, Sairu talked about the role of PRI. So we very, very meaningfully engage with the Panchayati Raj institution by converging on their Sankalp 2. Their Sankalp 2 is Swasth Village. So we brought TB agenda into that. So breaking the silos, meeting the same group together, conducting those workshops with the program managers and the civil society representatives and the TB survivors on the same table as trainees. So that, and those meetings were there, be it Panchayat meeting, be it Panchayat sensitization meeting, be it ACSM meeting, be it community engagement meeting. So they were there. So this is how we are able to get terms from TB champions today. I'm so proud to say that TB champions saying, I bought these many, lost to follow-ups. Somebody talking about bringing the loss to follow-up, and I got the end of the day end of the treatment culture. So that kind of capacity building of those, and that each partners working in different geography, uniformly working. So that was one innovation. Building on that, again, India was the first country, and to have that crowdsourcing, or we heard it was based on a lot of inputs the ministry was getting, that a lot of corporates want to work. How can we help? So the TB, Pradhan Mantri TB Mukt Bharat Abhiyan was launched, where any individual can come and support the extra nutrition. What it did was a positive spin on the stigma, and when you do it in a function, when a Gram Pradhan has become an Ikshya and it takes time. Stigma is very, very deep rooted. It takes time. But then this was one innovation where it not only improves the treatment outcomes by getting the extra nutrition plus a dent on stigma. The latest one is the 100-day campaign, where now that we have closed that gap of the missing million. A lot of talk has been, was there on prevention. So this is the right time. The estimated cases is 2.7 million. So we found 2.6 million last year. So right time to actually going to subclinical TB. The first session was subclinical TB. Going to vulnerable population, screening them, putting them treatment. So we closed that tab. So again, the community engagement was one very, very important component in that whole strategy, because of main mobilization by frontline health workers plus our TB survivors who worked in tandem. And as I said, the institutional mechanism of the TB forum, we conducted about 4 national TB forums. In each forum, when the Secretary Health is talking directly to the community and listening to their issues, and they, with conviction, bringing the mirror, we have say medicine shortage, or the stigma still is there, this was the issue. So that is, one thing which I would say we brought it. And the states have gone beyond. I mean, there are block level TB forums where issues are being said, and the way we engage with panchayats. Just to say, in this 100-day campaign, just to give you some figures, I mean, more than 3,000 elected representatives were actively participating in this campaign. One can imagine 162 plus member of parliaments, 400 plus MLAs, close to 2,900 MLCs. I mean the local bodies, urban bodies, and PRIs. Imagine one member of parliament represents about 20 lakh minimum, or maybe somewhere around that, and taking part in those meetings. So we are moving towards that Jan Andolan. And the challenge with making it a people's movement is the epidemiology of the disease, because I can take the disease, I can hide the disease, I can take treatment for 6 months, and I don't want to, I don't have to tell anyone. So epidemiology of the disease is very, very important challenge. Still in this last 6 years, with all the partners and the state program officers and the district program officers and of course the frontline workers, we were able to dream this 100-day campaign where we are actually trying to put, and we found 1.8 lakh asymptomatic TB patients. Otherwise, they would have gone out of the net. I think in the interest, I have a lot of the things to say, but I think leaving no one behind and giving the respect, place on a chair. So all mechanisms are there in the program. All our expert committees have some civil society representatives. Initially, as I said, the constitution was not as it was envisaged. Slowly, the composition in the forums is also improving. And the example is that during this 100-day campaigns, our ASNMD has spoken to the community directly twice. Just to take their feedback, okay, what's there? So that's let's not go defensive, defending everything, and let's take the feedback in a positive manner. That has been the real, I would say, positive outcome of having those workshops where the program officers plus the TB, survivors, civil society, they sit there for 2 days, 3 days, and that. It is difficult because the moment somebody gives you your shortcomings, you are bound to be defensive. So it will take its time. But I think in the last about 6 years, we could able to get the community as an important stakeholder. Still miles to go, and we want to. The role is to have community in all facets of the program activities, from policy formulation to program planning. What Blessina said, that you should start since beginning. I think the strategy, the Sigma document was the example in case that it all started with all the stakeholders, and then we worked together in trying to implement it. And of course, COVID had its own bearing on that. But I think I'll stop here. Last point about sustainability. Blessina said that yes, projects have different energy, they have different budgets, so they work well for some time, but when you move out, then there are issues. But successfully, the program has been able to transition it to the domestic budget, and but yes, implementation is a little differential. Some states have budgeted for engaging the TB champions in much more meaningful manner. I'll stop there, but if there are any other questions, we will ready to answer. Thank you.
Thank you, sir. Thank you. That was very, very well-rounded up session, and I don't think I need to add on anything more. But just to say that we've heard a range of community engagement innovations that are happening, whether utilizing platforms, panchayats, whether utilizing community care models, whether bringing in collectives like the women collectives. But I think what I heard across the panel was the emphatic understanding that the community at the end of the day, individuals who are affected by TB, they should and rightly be at the center of any kind of community engagements that we are thinking of. Several challenges around that, but several possibilities also around that. And probably those are some of those challenges and possibilities that can be taken up in the future in terms of research priorities. I thank the entire panel for giving me this opportunity to sit with you and have this engaging discussion. Thank you a lot.
Thank you so much, Kamalini, for moderating such a good panel. And it was like a very engaging sorts of discussions and very rich discussions. I request moderator to hand over the mementos to all the panelists. Yeah, it is such an engaging discussion. So even though that the time got a bit overshoot, but this is an important topic. So we really don't want to stop that topic in between. That's why it went a bit overshoot. That's fine with us, because community's voices we really need to hear, and community engagement is the thing that we are actually an important point that we are talking from the morning onwards. In this hall, what we are going to have is an important 2 small sessions on the opportunities for the innovators. What are the opportunities in the government departments for the innovators? For speaking about that, we have Dr. Sujita Markan, scientist from the ICMR. So we would hear from Dr. Sujita Markan, important opportunities in the government sectors for innovators. It's a very short lecture. Followed by that, there is another short lecture on opportunities available for innovations under PRIP scheme. Again, another important scheme of the PRIP scheme. But let's now hear to Dr. Sujita Markan on the opportunities for innovators from the government.